morning, everyone. Today, I'm going to be talking to you guys about how to get your ACS together and some STEMI equivalents I want you to look out for. I don't have any financial disclosures or any disclosures for that matter. How exactly am I going to help you guys get your ACS together? Well, hopefully by the end of this talk, you'll be able to better understand some of the risks that lie ahead of us when it comes to chest pain and ACS. And also you'll be able to recognize some STEMI equivalents that will not only save your patient, but save you from court. I want to start this talk off by talking about old Greg here. Greg is in his mid-60s. He's coming into your department today because he's having chest pain. He said it started about 30 minutes ago. It's on the left side. It's going down his left arm. He looks quite uncomfortable. You're looking at him. He's sweating bullets. He says he's nauseous. He looks like he's actually going to throw up on you, and then he does. He tells you he's a smoker. He's got hypertension and high cholesterol. And oh yeah, he's had a heart attack before, and it feels just like this. So you go ahead and get yourself an EKG. Your tech hands it over to you. Her eyes are wide because she's already read the EKG interpretation that the machine has spit out. And bam, he's got ST elevations in the inferior leads. He's got reciprocal depressions. You have yourself a true inferior STEMI. You know what you're doing next. You're already in an autopilot mode. You order some aspirin, you get the cath lab on the line and tell them to come in because you have an inferior STEMI that they need to take to the lab. You get him there on his merry way within 20 minutes, which is a record time for you. Another life saved, right? Now, if every ACS patient could be this straightforward, that would be amazing. But unfortunately, we know they're not. It shouldn't come to surprise to any of you that chest pain is one of the most common chief complaints that we see here in our ED. It accounts for at least 8 to 10 million visits in the ED per year. Chest pain is here to stay until the end of time. Unfortunately, because of that, it's also going to be the most common source of ED malpractice claims. Now, why is that? Studies show that approximately 2% of patients with ACS are inappropriately discharged from the ED when they shouldn't be. Not surprisingly, these patients end up having nearly twice the mortality rate of those who do end up being admitted for an ACS workup. Now, going back to the 2% of patients who end up being discharged, they make up 20% of malpractice claims against ED physicians. What's the most frequently alleged misdiagnosis? It happens to be MIs. And because of that, it ends up also having the highest payout rate of all claims just because of the severe devastation it can cause to these individuals as well as their families. Interestingly enough, alongside these suits, there are also more judgments when it comes to alleged delay in care. So where are we going wrong with ACS? What are we doing or not doing that is getting us into trouble? We know that patients with classic risk factors such as hyperlipidemia, tobacco use, and even strong family history of cardiac disease are likely to present typically. So what patients are we actually missing? What are we missing? It turns out that we might actually be missing atypical chest pain for one. Approximately 26 to 34% of these patients can have an atypical presentation or non-traditional chest pain. And we've all probably experienced this too. You might have had that one patient who's already come in with some vague complaint. Maybe they are saying they're feeling a little bit weak or fatigued, and our spidey senses go off on them because we end up ordering that troponin and EKG for good measure. Their EKG comes back non-diagnostic, looks similar to prior EKGs in the past, and the next thing you know, you've moved on to your next patient, the lab calls you and they say, hey, were you expecting such a high troponin? Because this is what it is. These are the folks that end up keeping us on our toes. When we think about who might have atypical chest pain or non-traditional chest pain, we might think of our female patients, our diabetics, or our elderly patients. Studies have shown that women who have ACS tend to be older, have a history of hypertension, and more likely to delay their presentation to the hospital. There's also currently plenty of literature out there about how women with ACS may also present with nonspecific symptoms. These nonspecific symptoms might include dizziness, fatigue, maybe a loss of appetite, or even something scarier such as syncope when they're actually experiencing an MI instead. What about our diabetics? Well, apparently 40% of diabetics who are actually having acute MI may also present atypically, as well as our elderly friends who anyone who is above the age of 65 may present non-traditionally. What are some of the common complaints in these two patient populations? Well, they might actually present with shortness of breath, nausea or vomiting, weakness or fatigue. Those are things to look out, especially in our diabetics and elderly. The good thing about them, though, is that they're less likely to be misdiagnosed, probably because we are already on high alert when we see these patients. When it comes to the other things for atypical chest pain, such as young patients, patients who might be complaining of GERD symptoms, their chest pain might be in a location that we aren't considering, or it might actually be reproducible. That's something that we're going to talk about in the next few slides. For the purpose of my talk, young patients are actually going to be ones who are defined as those less than 45 years of age. I'm sure if you worked in the last few days in the ED, you might have had someone check in the age of 20 to 30s who are saying that they're coming in for chest pain to make sure everything is okay, just in case. You probably already knew what their dispo was going to be as soon as you stepped into the room and saw them scrolling on their phones, right? They're probably going to be discharged, and you might not have been able, or you weren't even considering doing a extensive workup on them. And I want to give you pause about that because young patients make up approximately 10% of acute MIs annually. Literature suggests that these patients are misdiagnosed because they are younger, and we are considering them to have non-cardiac chest pain instead of something like ACS. When they do come in with ACS, they're more likely to present with features that we classically associate with ischemic chest pain. Studies have also seen that young patients with ACS are also going to present without ever having any prior episodes of angina before. So this is going to hit you right in the face. This is something that we need to stay on top of and also keep in the back of our minds, especially as the prevalence of heart disease increases among these patients. And that's due to the increasing rates of obesity, insulin resistance, as well as metabolic syndrome that we're seeing in this patient population, and it's only probably going to get worse. Let's talk about the location of pain now. When we're talking to our patients, we tend to ask them where their chest pain is. We used to think way back when that if they're having pain on the right side of their chest, then it actually doesn't matter. It's not going to be ACS. That turned out to be wrong. And it turns out it doesn't matter in terms of their likelihood of where that pain is, left, right, middle, because it could all be ACS. What about if the pain is going down their left arm or right arm? What about if it's going down both? Now, all of those things actually indicate a higher probability of ACS, with the right side and bilateral radiation nature of the pain can be a higher likelihood of ACS in general. Now, what about your patients who are having epigastric pain? Acute MIs can present with epigastric pain. So be suspicious of patients who are coming in with this complaint. It could be very easy to go down a GI pathway, especially if they're complaining of a little bit of nausea and vomiting. Do your thorough exam, make sure they actually have epigastric abdominal tenderness. If they don't, ask yourself if it could really be ACS instead, especially if they have the appropriate risk factors kind of match up with that. With these patients, I suggest that you guys have a lower threshold to get an EKG for them. It costs nothing, especially in the grand scheme of things, when it comes to the devastation that it could cause if you miss ACS on someone with epigastric pain, but no tenderness whatsoever, and the appropriate risk factors. You might also have patients who have chest wall tenderness or reproducible chest pain. Sure, there's a low likelihood that this could be associated with ACS, especially if they're doing windmills in front of you saying like, yeah, that's what's aggravating my pain, and that's the same kind of pain that I'm having. Definitely could all be cartilage pain. But use this cautiously because at least 7% of patients who have pain that is reproducible with palpation can actually have ACS. Are you poking a frail elderly lady that's in front of you and she's saying, ow, that hurts? Of course, she's 90 pounds soaking wet. Of course, it's going to hurt when you're poking her. I want you to take another step when you are eliciting pain with palpation. Make sure you're asking them if it's the same type of chest pain that is what brought them into the ED. If not, pause. Consider if it's actually ACS versus this cartilage pain that you might be leaning towards because you're getting that reproducible pain. They're not saying no. Again, move forward with that. Now, when it comes to acid reflux, the water gets a little bit murkier here, right? Their symptoms can confuse their overall picture. And that's because at least 20% of ACS patients may describe their chest pain as heartburn instead. Now, you've probably had a patient at some point in time who was complaining of some very vague chest pain that you decided to just treat with your GI cocktail of choice. You ordered it, checked on them anywhere between 30 minutes to an hour later, and they said that their chest pain had improved. Their problem went away, so your problem went away. You don't have to think about ACS anymore. Well, studies have actually shown that the relief of chest pain with a GI cocktail does not predict the absence of an MI. In fact, 15% of ACS patients will respond to antacids. There have been some studies out there in patients with heart disease in particular where they'll instill hydrochloric acid into their distal esophagus, and they see that the coronary blood flow in these patients gets reduced. So it only makes sense that when you're giving antacids to these patients, you're improving their blood flow and therefore improving the relief that they're having. So the bottom line is, I don't want you to rely on the response to antacids as a reason that they can't possibly be having ACS. When it comes to chest pain, what are some common risk factors or pitfalls that might land you in hot waters with malpractice? You can have missed or delayed diagnosis of an acute MI. Again, think back to the 2% of inappropriately discharged patients with an acute MI or ACS. There's also misinterpretation of EKG, as many in 1 in 4 missed MIs might have actually been prevented by a correct EKG interpretation. And on top of that, 25 to 50% of malpractice cases actually involve EKG misreads. That's a lot. There's also the failure to get an EKG. You might be setting yourself up for failure by not even considering ACS to begin with. Think about all those atypical presentations that we just talked about. Failure to get an EKG can also be an issue. How many of you have been sitting on shift, you get handed the EKG, the baseline is all over the place, there's so much artifact, and the tech looks at you and says, this is actually the best that we can do. Sorry, do you want me to repeat it? And you kind of look at it, you resign yourself, and you just end up signing it. You might also be handed an EKG that's non-diagnostic, and your patient is still having chest pain. Then you don't end up actually repeating it at all. Serial EKGs can actually identify an additional 16% of acute MIs that aren't seen on the initial EKG. So just repeat it. It could seriously change your management and save that patient's life. Last but not least, not getting a good history, I should say, should get you into some trouble as well. History taking is essential. I honestly can't stress this enough. The majority of malpractice cases involve a failure to recognize concerning features in the patient's history. Make sure you're asking them how long they're having their pain. Ask if it's been intermittent. All right, if it's intermittent, how long does the pain last for when it is there? Does it go anywhere to your jaw, to your arm, to your neck? What makes it worse? What makes it better? Are you having any nausea or shortness of breath or any other symptoms with it? Make sure you're doing the basic stuff that you were taught to do as a medical student, whether it's PQRST or even old cards. Just make sure you're getting a good and thorough history. Without an appropriate history, you might not be assessing for risk factors that might lead you to consider ACS more highly, or it could cause you to anchor on something else because you're not considering ACS when they're presenting with atypical presentation features that we just talked about. Again, think about those patients with vague symptoms and the patient population in front of you that you're dealing with currently. Maybe sometimes we're not asking the right questions to our patient. They don't read our textbooks after all. I remember I had a patient once who I asked, tell me more about your chest pain. And she responded as if I had asked the weirdest question in the world and said, I'm not having any chest pain, I'm having chest pressure. She said it as if it made the whole difference in the world. So make sure that you are double checking your patients. In addition to double checking your patients, make sure you're double checking your triage notes or your nursing notes. Some of these may reveal a discrepancy that you weren't even aware of. In Baltimore, we have patients who might come in with a laundry list of symptoms. Sometimes chest pain might be one of their 5 complaints that they are coming in with today, and they might be missing it because they are focused on the diarrhea that's been going on for the last 3 months. Make sure you're not missing ACS by just covering the most simple bases here. And something else to be aware of is asking about non-traditional risk factors that might actually increase their risk for cardiovascular disease. You can ask about cocaine use, which is a cause of MIs, especially with its use increasing in the younger patient population today, and is also responsible for about 25% of patients of MIs in these patients. Lastly, I also want you to think about your HIV or your lupus patients. Multiple studies have shown that HIV patients have at least 50% increased risk of MI. And additionally, cardiovascular disease is the leading cause of death in patients who have lupus. They are at risk of developing atherosclerotic disease much earlier compared to patients who don't have similar disease processes. So I encourage you to think about your other risk factors. Going back to this list, we can see a common theme here, right? It's the EKGs. At least 3 of these items are all about EKGs. And why is that? Remember, the American Heart Association, the American College of Cardiology, recommends that patients with suspected ACS should get an EKG and have it interpreted within 10 minutes. There's a reason why you are getting bombarded left and right during your shift with EKGs that you need to look at and sign. Is it a STEMI or not a STEMI? Things get easy to miss, especially such as ST depressions or T wave inversions, or maybe you don't have a chance to look at prior EKGs to see if that feature was there before in the past. When it comes to malpractice, we can't completely eliminate our risk. There's never going to be a time when it is going to be zero. What we can do instead is aim to be better on most things on this list. Maybe after this talk, I'll become this little angel or floating head on your shoulder that basically whispers and reminds you to get a full history or get or repeat the EKG. But maybe also I'll become a floating head to help you with these first two aspects, missed or delayed diagnosis and misinterpretation of EKGs. And I hope to get you there by talking about the STEMI equivalent so you don't miss anything crucial. Now, the inferior MI that I showed you at the beginning of this talk was pretty obvious, right? But not all patients who are actively infarcting are going to be that obvious. Maybe it's a more subtle EKG or it's a change that you're not quite knowing what to do with. Approximately half of the patients with an occlusive MI fail to actually meet STEMI criteria. This in itself results in delays in cath lab activations and that early benefit of getting those vessels reperfused. There's also increasing evidence that there are distinct EKG patterns that indicate these occlusive infarcts, and we're going to go through what some of these are. Hopefully, by looking at the list up here, that you've already begun to recognize some of them, or you've already seen them in practice. You have your Wellens syndrome, De Winter's, posterior MI. These are all things that you might have already set up with your cardiology at your institution, depending on what they think is important. And you might already be activating the cath lab for some of these. There's also something to consider when it comes to STEMI equivalents, which is there are more recent talks in lately about moving away from STEMI and non-STEMI and going towards occlusive MI versus non-occlusive MI, because these are all things that lead to occlusion. In 2022, the American Cardiology College of Cardiology caught up to the rest of the world, and they officially recognized these 4 patterns: hyperacute T waves, De Winter's, posterior MI, and Sgarbossa. They recognize them as STEMI equivalents, and therefore you should continue with the STEMI protocol for these. Now, the last 2 are probably less surprising, as people have probably been activating the cath lab for these way before 2022. So that's just something that it's nice that the ACC has finally got on board with us. The first pattern I'm going to discuss is the Wellens pattern. The Wellens pattern itself is an acute reperfusion of an LAD occlusion. Typically, by the time you see this pattern, the patient's probably already asymptomatic, but they did complain of chest pain beforehand. You might also notice that the troponins for these patients are normal or even just minimally elevated. The key of Wellens syndrome is knowing that it is a transient occlusion, and therefore, when you finally get the EKG is going to show reperfusion. What you're going to see with Wellens in particular is a biphasic or deeply inverted T wave in leads V2 and V3. You won't see any Q waves associated with it. Now, as I mentioned, there are 2 patterns, but the deep T wave inversion of pattern B is going to be quite hard to miss. So I want you guys to focus on pattern A here, that biphasic T wave. Over days to weeks, that pattern can slowly evolve, and that's why the deep T wave inversion is going to be a more common thing to recognize. These EKG findings in Wellens is going to last for weeks. It's not going to go away itself until the lesion itself is treated, whether it's from CABG or reperfusion. And large percentage of these patients who present with Wellens have also been shown to develop an extensive interior MI. And that's why it's important that you guys recognize it and discuss with your cardiology team early on. This first EKG here is actually of a young guy who presented to our ED here at the University of Maryland. He was having chest pain, but by the time they hooked him up and got him in our ED for this EKG, his chest pain had completely resolved. Now you can see here your focus is going to be on V2 and V3, and you're going to see that classic biphasic T wave that is Wellens syndrome right here. Moving on to another EKG where, again, your focus is on V2 and V3, which are going to be your money leads. And this is another example of that biphasic nature here, classic for Wellens. When it comes to hyperacute T waves, these actually often represent an early sign of occlusion before you're going to see ST elevations or any ST depressions. You'll typically see these very large, broad T waves in proportion to the height of a QRS complex that's next to it. The way I learned it and the way that I drilled it into my mind is if your QRS complex is small enough to essentially fit inside the area underneath the T wave, then it's likely a hyperacute T wave. These hyperacute T waves should evolve over time into a STEMI, or if there's reperfusion, they might actually normalize. As I mentioned before, the ACC recommendations recognize this as a STEMI equivalent. However, I feel that I should clarify because when you're actually reading the guidelines, they make specific mention for this pattern only to obtain serial EKGs over a short interval just to make sure that they actually progress to a STEMI. This is probably because there are other potential causes for similar appearing T waves, whether that's hyperkalemia or LVH or something else, that these shouldn't be going to the cath lab. So be mindful of the mimics that you might exist out there and be sure to repeat your EKG for any development before you activate your cath lab. Again, here's the hyperacute T wave. This is going to be essentially any leads that represent that vessel. And this one in particular is 100% LAD occlusion, especially looking at V2 and V3 here. You can see how small that QRS complex is in comparison to that T wave. It can essentially nestle its way in there, and that represents ischemia. Now, this one is going to be a bit harder to see, but I'm going to give you a second to see if you can recognize it. And if not, it's okay because I'm going to zoom in here on the inferior leads where you'll see that these are actually hyperacute T waves. Now, the T wave itself isn't all that impressive, but when you compare it to that small QRS complex, it is. So remember, it's all about the proportion of the QRS complex and the T wave. Moving on to the De Winter's pattern, another pattern that the ACC would like you to activate the cath lab for. The De Winter's pattern is actually pretty uncommon and still poorly unrecognized, and your EKG machine is definitely not going to be able to recognize this. The De Winter's pattern was first described in 2008, and fun fact, Wellens actually helped him with this pattern recognition in the paper, and it occurs in less than 2% of all acute anterior MIs. It is an unstable proximal occlusion of the LAD, and it can also be thought to be a subset of hyperacute T waves. With the De Winter's pattern itself, you'll see an upward sloping of the T wave into this tall symmetrical T wave here. It'll be an ST depression and leads V1 through 6, your precordial leads, and then it'll shoot up into this tall symmetrical T wave. You might also sometimes see some ST elevation in AVR. Unlike hyperacute T waves, these T waves should be stable over time. So here I have that same EKG for you where you see that ST depression, the precordial leads, and it shoots up into that tall T wave. And you might also notice that slight elevation AVR that I was talking about. Same here, same thing here. If you look at the precordial leads, ST depressions, and those tall, tall symmetric T waves. We also have posterior MIs as a STEMI equivalent. These are also going to be very rare. These are left circumflex occlusions, which account for most posterior MIs. About 5% of these MIs are going to be isolated, but you can also see them with inferior or lateral MIs as well. These MIs can be easily missed because they actually don't show ST elevation with a standard 12 lead. Instead, you're going to see the ST depression leads V1 through V4, representing that ischemia over that posterior heart. The ST depression in these leads can also be misinterpreted as anterior ischemia. So that's just something to consider when you have a posterior MI, and you should be more alert of this. You'll see these really tall R waves as well, and that should give you a hint that there is some badness going on. So here is a EKG here showing those ST depressions along with those tall T waves as well. And again, V2 through V4, you can definitely see it there. When you get or you see those ST depressions with the tall R waves, I want you to go ahead and get yourself a posterior EKG if you're concerned that there could be a posterior MI. It's pretty simple. You just have to move your leads V4 through V6 onto the left posterior chest wall and rename them to V7, V8, and V9. Once you go ahead and get that EKG, you're going to look for any kind of ST elevation in those posterior leads. There only needs to be half a millimeter of elevation for you to consider posterior MI. If you're still having high clinical suspicion in these patients and you're not seeing that elevation in at least one lead, then go ahead and repeat that EKG, because initial posterior lead EKGs might not always meet STEMI criteria on the first one. Moving on to Aslanger's pattern. This pattern was first described in 2020 by Dr. Aslanger himself. He was looking at a bunch of EKGs of NSTEMI patients, and he noticed that approximately 6.3% of these patients had this particular pattern. He found it to be a pattern that was predictor of very large infarct size, and that was based off a 24-hour troponin, and he also found that these patients had higher mortality. So this is going to be a left circumflex occlusion, but it can also be associated with an occlusion of the RCA as well. It can be distinguished by ST elevations in lead 3 and none other in the inferior leads. And then you're also going to see some ST segments in V1 and V2. You may also see ST depressions anywhere in V4 and V6 as well. So again, here you're going to see the ST elevation in lead 3 only, and then you're going to see depressions here in V4 and V6. Again, lead 3 is going to be the lead with the ST elevation, and the other leads are going to have ST depressions in V4 and V6. With Aslanger's in particular, you end up having a 5-fold increase in in-hospital mortality if you don't diagnose this promptly. Moving on to the South African flag sign, which is pretty fun. It is a very rare sign and pattern, and with this EKG pattern in particular, you're going to be looking for ST elevations in leads 1, AVL, and V2. That's going to signify an occlusion of the first diagonal branch of the LAD. And the South African flag sign gets its name because of this green portion that you might see here. The elevated leads in 1 AVL and V2 and the depressed lead in lead 3 fit within the green central portion of the South African flag. I actually didn't know what this flag looked like until I learned a little bit more about this sign. Sometimes the ST elevation can actually be a bit subtle, and it's going to be something that you might actually miss in terms of this pattern in general, because you have contiguous lead elevation here. You might just not recognize it because 1 and AVL don't sit next to each other. So be aware, 1, AVL, V2 are going to be your elevation leads, and lead 3 is going to be your ST depression lead. So here is an EKG that signifies that South African flag sign. If you can't see it already, I put in that green portion here for you that overlaps 1, AVL, and V2, which have your ST elevations, and your lead 3, which has your ST depression. If you still can't see the South African flag yet, I hope that made it a little bit easier for you. Here's another example of the South African flag sign. Again, you have leads in 1, AVL, and V2 that have the ST elevation, and lead 3 is going to continue to show your ST depression. Last but not least, Sgarbossa. Now, left bundle branch blocks and right ventricular pace rhythms can mask MIs because of the changes in repolarization findings. Turns out about 80% of left bundle branch MIs are not detectable. Now, Sgarbossa and friends proposed the following 3 criteria to kind of help with this and to diagnose a STEMI in these patients. And they used either the concordance or excessive disconcordance of ST segments and the QRS complex. With concordance, basically it's meaning it's going in the same direction, and discordance, it's going in the opposite direction. So if you find the presence of criteria A or B, then it's considered diagnostic of an MI. If it's criteria C, then it's a little bit less specific. So when you're looking for a Sgarbossa in a left bundle branch block or a paced rhythm, you're going to want to go through this in a very methodical method here. You're going to start with criteria A, which looks for any concordant ST elevation greater than 1 millimeter in any lead. If you see that, you're done. That's a STEMI right there. If not, move on to criteria B and look for any concordant ST depression more than 1 millimeter in V1s, V2, or V3. Again, if you see that, then you can go ahead and stop. If not, you move on to criteria C, which looks for that excessive discordant ST elevation that's greater than 5 millimeters. Now, I said that this was an ACC recognized STEMI equivalent, and it is, but it actually uses the Smith modified Sgarbossa criteria instead. That is just because it's found to be more specific for MI for all three criteria here instead of just two in the Sgarbossa only criteria. And the main change here is in criteria C, where instead of they're using that fixed ratio, they're using the ST elevation height to S wave ratio of greater than 25%. So if you look at here in this EKG, you want to start off with criteria A, see if there's any ST elevation that is concordant in any lead. There doesn't appear to be any here, so you move on to criteria B, which is looking for concordant ST depression, and again, it is not. But if you look a little bit closer to V2 and V3, you do see that discordant ST elevation in V2. Here's another EKG. I'll give you a second to see if you can spot anything right off the bat in terms of criteria A and criteria B. And what you'll actually see is criteria A is met in V5 here. You have that concordant ST elevation. And if you look a little bit closely, you also have modified C criteria met in V3 here, which is that discordant ST elevation as well. So leaving you all here with some take-home points. I just want you guys to all to beware of atypical presentations. Make sure you're treating your patient, not just the EKG. Look out for your STEMI equivalents and be ready to activate your cath lab team. Don't be afraid to get or repeat your EKG. And lastly, history is so important. Make sure you're getting a thorough history, assessing for risk factors, and documenting that. Thank you.